Gestational diabetes mellitus, or GDM, is a subtype of diabetes mellitus that occurs during pregnancy in someone who was not diabetic prior. Gestational diabetes is a condition where there is an unusually high level of glucose in the blood, secondary to maternal insulin resistance. As you can see, gestational diabetes mellitus is rapidly growing and is the fastest growing type of diabetes in Australia, with incidence rates more than doubling since 2011. With risk factors continuing to climb, it is expected that the rates of GDM will continue to rise. To start off with today, we'll run through the normal process of regulating blood sugar levels. Then we'll look at the normal changes in pregnancy and how this goes wrong in gestational diabetes. Finally, we'll cover the complications of the disease and relevance to paramedics. Normally, when we eat a meal, carbohydrates are broken down into glucose and absorbed into the bloodstream, rising our blood glucose levels. Our pancreas detects this change in blood glucose level. This occurs in the pancreatic islets, which are small units found throughout the pancreas. They contain beta cells, which detect this change and release insulin in response into the bloodstream. These islets have other cell types too, namely alpha cells, which are responsible for releasing glucagon. However, the release of insulin also inhibits the release of glucagon from these cells. Insulin travels through the bloodstream and attaches to insulin receptors found on various cell types, including on skeletal muscle, heart, and adipose tissues. This causes glucose transporters, specifically GLUT4, to translocate from the intracellular space into the cell membrane. These transporters allow glucose to enter the cells where it is used for energy production and storage, lowering blood glucose level. In the liver, insulin promotes the uptake of glucose where it is converted to glycogen through a process called glycogenesis. Glycogen is able to be stored for later use. Insulin also affects adipose cells called adipocytes, where it promotes lipogenesis, or the conversion of glucose into triglycerides, also used for energy storage. Glucagon, which we said is also released from the islets, does the opposite. It promotes the breakdown of glycogen into glucose through glycogenolysis and triglycerides into glycerol and fatty acids for energy use. During pregnancy, the body creates a new organ in the uterus called the placenta. The role of the placenta is to support the development of the fetus by transporting nutrients and waste between the fetus and the parent. Additionally, the placenta signals changes in the body to support ongoing care of the fetus, adapt to new physiological demands, and prepare for labour. To achieve this, the placenta releases a variety of hormones. Some of these influence blood glucose, including human placental lactogen, or HPL, human placental growth hormone, or HPGH, and corticotropin releasing hormone, which leads to increased cortisol release. HPL is the primary driver of insulin resistance. It does this by increasing maternal cells' insulin resistance, making them less responsive to insulin. HPL inhibits the internal process that normally results in GLUT4 translocation. This leads to less uptake and utilization of glucose from the blood. Additionally, HPL promotes lipolysis, or the breakdown of fats into free fatty acids, which can be used in place of glucose. HPGH and cortisol also promote lipolysis and interfere with insulin signaling similar to HPL. Interestingly, this lipolysis also inhibits the transport of glucose into the cells, leaving more glucose in the circulation. In the pancreas, cortisol acts on alpha cells to release more glucagon, and in the liver, HBGH, cortisol, and the newly formed glucagon stimulate gluconeogenesis, which is the production of glucose from other sources such as amino acids. Overall, this mix increased blood glucose along with maternal insulin resistance, allowing for the energy-hungry and growing fetus to get the glucose that it needs for development. It is important to note that this is not pathological and that in a healthy pregnancy, insulin sensitivity may drop by up to 70%, requiring up to 3 times as much insulin to maintain normal blood glucose range. In response to this, the pancreas undergoes hyperplasia of the beta cells. This increases the capacity of the pancreas to create insulin, leading to hyperinsulinemia. Insulin is normally released in 2 phases post-eating, the first being a large amount of insulin over 5 minutes to overcome the sudden spike in increased glucose, and the second phase being a longer phase to maintain normal blood glucose levels. In gestational diabetes, these beta cells may dysfunction or not multiply enough to overcome this increased glucose supply and insulin resistance. The first phase of insulin release is particularly blunted, making it difficult to return to baseline post-eating. Additionally, an overabundance of free fatty acids, along with other insulin resistance causing hormones, may result in resistance that the maternal body is unable to overcome. Although the exact cause of GDM is still being researched, it is believed to be a result of a mix of these and other hormones. Prolonged hyperglycemia also damages the beta cells directly as they continue to try producing more insulin, eventually leading to beta cell apoptosis. This is called glucotoxicity and further worsens the pancreas's ability to produce enough insulin. Because the cause of hyperglycemia is a result of the pregnancy, GDM normally resolves rapidly after birth. Screening is now routine during pregnancy between 24 and 28 weeks gestation, when GDM is most commonly developed. GDM may develop earlier or be missed, particularly in those without prenatal care. Screening usually occurs using an oral glucose tolerance test, where glucose is consumed while fasted and sugar levels are measured at 1 and 2 hours post-ingestion. There are often no signs reported until later in the pregnancy, if at all. When symptoms are reported, they are similar to type 2 diabetes and include polyuria, polydipsia, polyphagia or increased hunger, and fatigue. When attending these patients, paramedics will note an unusually high BGL. Risk factors for GDM include a family history of GDM or any other type of diabetes mellitus, obesity, pregnancy in older age, normally above 30 or 35 years, polycystic ovary syndrome, race, specifically Indigenous Australians, Asian, African, or South American descent, or pregnancies that involve more than one fetus. Complications are where the paramedics are most likely to be affected by GDM. GDM affects both the parent and the fetus. Maternal complications include preeclampsia, a condition characterized by high blood pressure with organ damage, which can progress to eclamptic seizures. While there is a clear association between GDM and preeclampsia, the exact cause is less clear. There is increased risk of cesarean delivery, and rarely there is a risk of diabetic ketoacidosis or hyperosmolar hyperglycemic state, 2 hyperglycemic emergencies. Finally, post-delivery, there is a risk of diabetes being developed later on in life. Neonatal complications include macrosomia or large birth weight, deformities such as cardiomyopathy or enlargement of the heart, hypoglycemia post-birth. The newborn has been relying on the high level of glucose from the mum and producing high levels of insulin in response. When the umbilical cord is cut, there's suddenly less glucose, and this creates a mismatch between the glucose and insulin, leading to hypoglycemia. Shoulder dystocia, which is a birthing complication as a result of the baby getting stuck in the pubic symphysis during the birthing process, and can lead to hypoxic injuries and fetal death if not rapidly rectified. Respiratory distress syndrome and resulting PICU admission, there is a risk of death, and later on in life in the baby, there is an increased risk of diabetes. The treatment depends on severity. Normally, it starts with diet-controlled, increased physical activity and weight management, along with self-monitoring of the BGL. However, as the diabetes progresses, it moves on to medications such as metformin and insulin. Pre-hospitally, it is important for us to get a good history and otherwise provide symptomatic management. If birthing at home, we need to be prepared for complications and the need for neonatal resuscitation and postpartum hemorrhage management. In summary, GDM is characterized by high BGL and insulin resistance during pregnancy. For paramedics, recognition is vital, particularly during birthing due to increased birthing complications such as shoulder dystocia, requiring neonatal resuscitation.